Good day, and welcome to Epstein Becker Green's webinar, Strategic Healthcare Investments, Part 1, Substance Abuse Disorder Providers. Before we begin today's presentation, please be informed that today's webinar is being recorded and the participant phone lines will be placed on mute throughout the program. You can submit questions throughout the program by using the Q&A feature provided by WebEx, and at the end of the program, with time permitting, speakers will address your questions. You're welcome to submit questions directly to the presenters following the webinar, and contact information will be displayed at the end of the presentation. In approximately 2 to 3 business days following the webinar, Epstein Becker Green will communicate the availability of the webinar recording and access to the PowerPoint materials. We have several fantastic speakers today from Epstein Becker Green, Edgemont Capital, and Yale Behavioral Health. I will introduce you to today's moderator, Gary Herschman, member of the firm in the Healthcare and Life Sciences practice, and the New York offices of Epstein Becker Green. Mr. Herschman advises and assists healthcare providers in strategically positioning themselves in the rapidly changing healthcare marketplace. This includes advising clients in regard to consolidations, affiliations, mergers, and acquisitions. At this time, I'd like to turn the webinar over to Gary.
Thank you very much. So, thanks everyone for joining us on this important webinar. Behavioral health services companies have been in growing demand over the last year, and all year there have been over 20 deals, averaging 4 or 5 per month. Populations, these behavioral health conditions continue to become more and more recognized, and there's great funding for these services, which is expected to grow even more in the future. We have a great panel to speak about this. I'll introduce the panel. Erik Kistler, Vice President at Edgemont Capital, an investment firm. He's been around for more than a decade and has covered almost all verticals within the healthcare industry, with responsibility for deal origination and execution of acquisition transactions and offerings. Scott Biggold is the Chief Operating Officer of Yale Behavioral Health and the Yale Program on Supervision. He is an assistant clinical professor in the Department of Psychiatry at the Yale School of Medicine. He was an organizational consultant in a statewide supervision competency development initiative that was funded through Connecticut's Mental Health Transformation State and Grant. He has conducted supervision to numerous Connecticut state agencies, including the Department of Mental Health and Addiction, Department of Corrections, Department of Children and Families, Connecticut Valley Hospital, as well as the District of Columbia's Department of Mental Health. Member of the firm at Epstein Becker Green and practices in healthcare committee, Washington, D.C. offices of Becker Green. He represents a broad range of healthcare provider and private equity clients in transformational corporate governance, compliance, oversight, strategic, and crisis management matters. Before joining Epstein Becker Green, Mr. Gilbert served as the Executive Vice President and Chief Legal Officer and Corporate Officer of a leading Fortune 500 healthcare system for more than 10 years. Final analyst Kevin Malone is an associate in the healthcare group at Epstein Becker Green in its DC office. He provides strategic and compliance issues involving Medicare, Medicaid, and other party reimbursement programs, with a particular focus on primary, post-acute, and long care, as well as behavioral health, disability support services, and obligations under the Mental Health Parity and Addiction Act. Epstein Becker, Malone served as the public health analyst with Substance Abuse and Mental Health Services Administration, and then joined CMS and was there for 6 years at the Department of Health and Human Services. So with that introduction and that phenomenal panel, I just want to talk briefly about the agenda. On slide 5, we're going to talk about recent activity, Denver's evaluation, and then a competitive process for transactions. How does this work if a company, one of your companies, is exploring potential partnership or sale situation? Then talk about preparing governance to avoid devaluation of your team and such type of competitive process. Then I'll focus on potential changes of these companies. And in the home stretch, we're going to talk about corporate housekeeping to prepare for a transaction, consider selecting my partner, and deal points. That being said, we're going to turn it over to Erik.
This is Erik Kistler. As Gary mentioned, I'm a vice president here at Edgemont Capital. We're a New York City-based M&A advisory firm focused exclusively on healthcare. And so, as Gary mentioned, I've spent my career focusing on several verticals within healthcare. And importantly, today's discussion, the focus around the substance abuse market and how it is positioned for growth today. As we'll come to learn over various slides here, there will be a recurring theme of why there is investment and hopefully walk away with an understanding of what will end up being a better thesis behind why deals are happening and how to better position yourselves for that. So to kick it off, I won't spend a whole lot of time on this first slide because you all on the call today understand this, but it really is driving what is actually the investment in the space. So favorable regulatory tailwinds, systemic need for cost-effective treatment, and highly fragmented market, which all three combined create this perfect storm for not only strategics like AAC and Acadia to go out and continue to build on their market share, but private equity groups to get in on the action. Many private equity groups have what we call a lemming mentality, whereas the group gets in first, and then 40 others actually want to understand why, and then you'll see several transactions that take place. So as we head here to kind of this next slide, it outlines the behavioral health M&A from 2011 to 2017, and specifically the substance abuse. In 2011, we saw 4 deals. In 16 and 17, we've seen 10. In 2018, we've already seen 5. Key trick here is while it looks like there has been a flat growth or it's stagnant, so keep in mind as we head to the next slide is these tend to move in cycles, especially where there is private equity investment. So you'll see here there are 12 equity-backed platforms, which is a word you'll hear several times as you start to consider an M&A process yourself. Are you a platform? Are you not a platform? What makes a platform? Of these 12, only one was done prior to 2015, which was Clearview Capital and Pyramid Healthcare. However, the reason why we highlight Pyramid Healthcare and Clearview, since 2011, they have made 8 add-on acquisitions, which is notable here because Clearview Capital doesn't necessarily have size fund as many of these other names that you see where you see private equity backer in the column. They're smaller funds, but it's still an opportunity to go out and acquire and put their money to work. The other thing to note of that's of importance here is any of these were either occurred in 2015, 2016, and 2 in 2017. The Halifax Group did the deal in 2017, and Summit Lee FFL did it in 2017. The years were a mix of 15 and 16. Typically, the timeline horizon for these groups are 3 to 5 years of a holding period, meaning when they close a transaction and invest in the platform opportunity, they like to hold these businesses for 3 to 5 years before they end up selling them again to either another private equity-backed platform or a private equity group which has not invested in the space, or a strategic like AAC or India. It is important to note this because, since 2015 and 16, we're already here in the 3rd year. So we're going to start to see, I think, if you looked at this opportunity again, looked at this slide again, in a year or two, we would see a much different landscape. A lot of these groups would either be have traded to a strategic or to another private equity platform. And why it's important on this next slide as we go to understand the differences and the pros and cons of doing each transaction and where your opportunities lie. So what I love to tell my potential clients or prospects, or even our own current clients, the best place and negotiation position to be in is to be able to look at a buyer base and say, we're okay with maintaining the status quo. And I don't mean that by looking to reinvest in the business or continue to grow the business, but what I mean by maintaining status quo is you don't need to do a transaction. Today is not a fire sale. There's no issues involved that you need to get rid of the business. Now, you move forward to the right of this page, there's a merger of equals, a new PE platform, partnering with an existing platform, and outright sale. I argue that of the people on the phone today, what may make most sense is to start thinking about the opportunities of part of the new PE platform, part of an existing platform, which goes back to the earlier slide of all those platforms that have private equity involvement already, or an outright sale to a strategic. And you can find, as you look at this slide, the second row here is the positives of doing a deal with 3 opportunities in mind, and the last row is the negatives. And I won't go through each, but something to keep in mind as you about this process, which I assume is something, if you're on the call today, is that you're considering either now, in the future, or 6 years from today, is it's broken, it's going to try to fix it. There's a lot of mentality out there around a private equity group. If I sell to them, they're going to fire my staff, or if I partner with an existing private equity platform, they're going to change the way I do things, or if I sell outright, I no longer have control over my business. While that may be true for the latter of selling to a strategic, the other two, that is not the case. And spend some more time on that offline about how those work. However, where I think starts to get very, interesting for folks is what the shareholder considerations are on the next slide. How should we be thinking about moving into a transaction? So we've talked about why there are deals happening. We've talked about who's doing deals. We've talked about what deals are available. And we're going to talk about why it makes sense for you to even consider the prior that we just mentioned. And so as you go through this, you need to have a good understanding of what you all want to get away from a transaction. What investment philosophy or the strategic approach from the potential acquirer? What is it that you want to do? Do you want to continue to grow the business because you see blue sky and a runway that's miles long? Or you're just ready to set off into the sunset, walk away, and pursue other avenues? Both are okay. However, you need to make sure as you navigate this process is right for you, because there is a right and wrong answer to that. If you were to tell me that you didn't want to do this anymore, I wouldn't tell you to sign up and look for a private equity transaction. Private equity is going to look to you to continue to grow the business. If you told me that you wanted to grow the business and you wanted to start 10 de novo locations and acquire your best friend that's in California, I argue that strategic is not the right option for you, because you're not going to have as much control. So as you continue to think about this, what are the benefits of each partner? What financial with all that equity groups? Are you going to have access to capital? What's that capital going to look like? How much are they going to look to lever up the business? What risk tolerance for debt? And in strategic, what is the market trading at? If you're going to hold paper post-close, and by hold paper, I mean, are they going to give you some upside in terms of holding the stock? Are you comfortable with where it's trading at? What is your negotiating partner power lie? With existing industry experience or related portfolio companies, they can provide something other than just money. Everybody's money is green. What else do they bring to the table? Do they have somebody on their team who has an ability to leverage contracts with payers? Do they have somebody who's done a great job of marketing in the substance abuse? Are they good with digital media as the industry starts to trend that way? The next thing to consider is autonomy. You know, it goes back to this idea of if it's not broken, they're not going to try to fix it. That being said, you are no longer going to be personally liable for any capital investments or debt in the business. You already get to rid yourself of that stress. There's no more sleepless nights wondering how you're going to come up with the money to pay for the EHR, or how you're going to open this new satellite site and make it come to fruition that it is a new location. It just starts to minimize the risks that are outside of your control. And final consideration and the benefits of doing a transaction is what your liquidity looks like. How much cash do you need in your pocket, and how much equity do you want to maintain going forward? And with a private equity group, you're going to get an opportunity to hold equity and roll equity and then participate in the upside. A strategic deal, you're going to get more cash in your pocket but limited upside. So now let's talk about, as we go to the next slide, how do you actually get value? What is a strategic or private equity group going to value you off? Let's be clear, it will not be revenue. We've heard this several times. It will be what is called EBITDA. Your earnings before interest, taxes, depreciation, and amortization. What's your operating income? If you looked at your P&L and you called your accountant today and said, I want to know what your net income is, I want to know what your operating income is. From there, you add other on the P&L, your interest, your taxes, depreciation, and amortization back. This is the best key performance indicator. Is your proxy for cash flow is EBITDA, and this is how every deal will be done. And it's going to be based off of a valuation multiple. So let's say, for sake of purposes, you had 10 million of EBITDA to just trading between, anywhere to 7 to 11 times. Times that 10 by 7 or times it by 11, and that's where you're going to arrive at your valuation. And what are the primary drivers of valuation? We head to the next slide. Things to consider as you look at this and what private equity groups and strategics are going to look for. What is your reputation in the market today? Are you known for your clinical excellence? Are you known for driving profitability? Do you have back office infrastructure? What is your compliance department look like? What has historical growth been? Are you acquisition naive? Meaning, have you ever done acquisitions? And if you haven't, have you carefully thought through who you could acquire in a deal post-close? All of these considerations are going to be taken into consideration not only by private equity groups, but strategics. However, there will be different emphasis on some of these for strategics than there will be on private equity, vice versa. These drivers of valuation. What does your payer mix look like? How is your ADC continue to grow? What is the quality and sophistication of your financial reporting and business tracking? Do you have cash basis financials, which is okay, or are you on an accrual basis, which they were going to want to see post-close, and when you get into a process will make you convert to? Are patient-centric focused, or are you not? Are you just turning and burning? Are you networked with large insurers? Now, the latter, I would say, for this and this crowd, in-network versus out-of-network, we could have a really long discussion around that, so we won't touch that today, but we can have a conversation offline. However, if you are out of network today, don't think that you're going to be immediately devalued, because it's not the case. And finally, what does the process actually entail, and how long does it take? I wish, as you head to the next slide, I wish I could sit here and tell you, 5 years ago, it was probably 3 to 6 months Now we're looking ever since, the 2008-2009 financial crisis, it's 5 to 9 months. Both on the private equity side and on the strategic side, everybody's dotting their I's and crossing their T's. And 3 things to keep in consideration are, as you look at a process like this, what are your priorities and objectives? Make sure you have a clear list of what you want to get away from a potential private equity group or a strategic buyer. What are the different types of processes you can run? We can run a process that is broad and go into 100 groups. We can run a process where it's very limited and we go to 5 and end up with the same result. It's really what you want to have, what your appetite for a process is. Don't let folks tell you need to do it one way or the other. That's not necessarily the case. And then ultimately, finally, at the end of this, preparation is paramount. Partner with the M&A advisor to do this. You need to make sure that your story is crisp, clear, and concise, and that everything you're in a row and everything makes sense when it comes down to what your growth strategy is, what your financials are, how you are aligned legally, which these guys can get into, how your diligence will shake out, making sure you have all your contracts in place, because at the end of the day, a process is time-consuming and going to be a strain and it's stressful, but ultimately, hopefully, at the end of the day, you walk away with some money in your pocket or a new partner to help grow that you're very comfortable with.
Thank you, Eric. I appreciate your presentation. It was very, very important. So as Eric is talking about a 5 to 9 month process, and one of the things everyone needs to understand is that if you're a buyer, investor, or partner for your business, that you putting in millions of dollars, and potentially in the tens of millions of dollars for investment, they are going to look you over upside down and inside out. So it's very important to understand and prepare for that type of what they call deep diligence on your company. So Miguel from Yale Behavioral Health has a lot of experience advising companies, substance abuse disorder companies in particular, and so I'll turn it over to Scott.
So my focus today is going to be on clinical due diligence and helping to avoid evaluation. The essence of what I'm going to present is really focused on the clinical underpinnings, though, of what is being purchased, so that you're clear about what's being purchased, what the idea is, and what the potential risks are. The principal objective, like I said, is establish clinical due diligence strategies to avoid devaluation in the transaction process through operations that balance both compliance and clinical excellence. And I want to highlight that. Oftentimes people tend to focus just on the regulatory or compliance side, and part of our approach is to ensure that those pieces are not only in place, but that entities are using clinical best practices and that the quality of care is high. Okay, so number one, in terms of devaluation strategies, is to look at the clinical skeletons. Regulatory concerns we always start with, and that begins with the certificate of need. For anyone that's not familiar with their certificate of need a CON every time you are acquiring a healthcare facility, initiating services, trading services, or transferring ownership. And some of those things become a lot more complex than they look at first blush. So that's key. The second is wherever it is you are going to provide services, you need a license. In talking about today, substance abuse, but licenses are typically ordered through departments of public health. And in a lot of states, there's both a substance abuse and a mental health license. So when you purchase a residential facility, you purchase a substance abuse facility type, and provide mental health services, you may need to get another license. If that's the case, you want to look into what that takes, and or if you would need to get a certificate of need that correlates with that, and directly relates to the issue of add-ons. So if you want to add programs on, you want to make sure that the certificate of need would be available. You can get a license for what it is that you want to provide. And I'll come back to that issue later. The second clinical skeleton area is that of recoupment and payments, paybacks. To look at managed care audits, understand if there have been compliance problems. So when we think of compliance, we typically think of quantitative and qualitative issues. Quantitative issues are those things like, are signatures there? Is there documentation of particular sessions? But areas tend to get a little more qualitative, which is, are they coding accurately? Sometimes agencies will do what we call upcoding, where instead of coding what they see in front of them, they upcode it, and by virtue of that, it gives them greater revenue. But if on audit, that money can be recouped by a managed care company. Then the other issue of medical necessity they'll talk about later. But medical necessity is a huge issue in terms of looking at clinical skeletons, because it's not uncommon. An agency will push patients into higher levels of care where there's not the requisite medical necessity. It looks like the volume of patients that they have is much greater than it really will be post-purchase. Look at action plans. Has any managed care company, has any payer created an action plan against the facility? One of the things that happens, if that's the case, is you can end up in prospective review. That before you get paid, the managed care company wants to see all of the documentation prior to payment. This is a particularly problematic issue as it relates to cash flow. You want to look at accreditation. Are they accredited through something like the Joint Commission or CARF? And if they're not accredited, you want to ask the specific question, has accreditation been lost? I've seen a couple of facilities around the country where they said they just weren't accredited until you ask the follow-up question, was it ever lost? And when accreditation is lost, that's a pretty significant issue for any facility. So you want to understand what that is. You want to look at critical incidents. Are there safety concerns? One of those critical incidents, I'll speak in a little while about the issue of staffing, but sometimes critical incidents relate to the issue of not having enough staff or the right staff. So understanding that piece is important. And then finally, under the overall revenue related to labs and drug testing. That is an area that's been under assault over the past couple of years by managed care companies. That directly relates to the issue of medical necessity, and for agencies that are holding their own labs, essentially referring to themselves, that's definitely a potential red flag. I want to just give everyone an overview as to what we call levels of care. And the reason I want to do that is when you're thinking about purchasing, oftentimes people think of purchasing something like a residential, and after that, people that are other kind of add-ons, but just all use the same language. And when we're talking about hours in relation to levels of care, we're always talking about face-to-face contact. That's just an important piece to remember in terms of behavioral health or substance abuse services, that when you bill for face-to-face time. One of the areas that becomes problematic at times with agencies, you bill for time where they're not actually with the patient, and typically there's no coding for that. So outpatient services, you're providing up to 9 hours a week for patients on an outpatient basis. It's what we call intensive outpatient services, where patients are typically come 3 days a week, 3 hours a day to the facility. Partial hospital is also an outpatient program, but patients are usually coming 4 to 5 days a week for up to 20 hours. Services are where patients are living at the facility, and usually the average length of stay is somewhere probably around 1 to 4 months. I should say the average length of stay for partial hospital is usually probably around 2 weeks. For an outpatient program, you're probably looking at a month, maybe 5 weeks. Then there's inpatient services, which an average length of stay is about 2 weeks. Those are obviously kind of the highest acuity of care. And, in this context, we're probably looking more at residential and services below that. You'll hear a lot about medication-assisted treatment, MAT, like methadone, buprenorphine, and naltrexone. Those can be provided at any one of these levels of care. And note that when you think about the provision of service and about add-ons, from a substance abuse perspective, if you can provide services from residential all the way down to outpatient, you've covered the continuum. If you can't cover the continuum, the problem is those patients will ultimately elsewhere, which then can be a problem in terms of your business modeling moving forward.
And this is Kevin Malone. I just wanted to jump in on that last slide real quickly and add that, I think for folks both acting as providers and really interested in acquisitions, I think this sort of levels of care infrastructure that went through is really is of course very accurate, but it's also an area where there's a lot of innovation happening, both in sort of payment policies. From especially the Medicaid program is in the midst of a lot of reform ideas with regards to especially the coverage of residential addiction treatment. There's been a lot of effort there for the first time in really the history of the program to allow for coverage of residential addiction treatment, which historically was subject to the IMD exclusion. And a lot of providers that are heavy in the Medicaid space should, in many states, this is obviously state-specific policy process, should be looking to that level of care if they haven't already. And in addition to MAT, there's a lot of effort right now around overdose reversal services and crisis management services that are things that a lot of payers are really interested in partnering with, a lot of public programs are interested in partnering with. And finally, I think although it's a high-risk area from a compliance perspective, there's also a lot of opportunities still around sober housing in conjunction with OP or PHP or OP services and sort of the traditional Florida model. Jurisdictions still are revising the regulatory approach to sober housing. There's obviously been an enormous amount of attention given, especially in high jurisdictions like Florida, to problematic use of those models and harmful use of those models and fraudulent activity. But it's also a way of expanding the revenue opportunity for an addiction treatment provider and making those OP, IOP, and PHP levels of care more effective. So sorry jumping in there, but wanted to sort of add a little of that sort of color about the way the market is changing that I think it should definitely be kept in mind.
Thanks. So I referenced earlier the importance of understanding medical necessity, and this is probably one of the greatest kind of risks that you have in terms of purchasing. It has kind of a qualitative element to it, but is the underlying concept at the end of the day to which all payment decisions are made. You need to look at payer and state-specific statutes, but understanding it is enormously important. So there's two pieces. There's the one piece where it relates to the medical record. And everything within that medical record, the progress notes, kind of understanding what each discipline is writing is enormously important in kind of totality. The other piece that you need to be aware of from a risk perspective is that agents will oftentimes say, well, I've already got prior authorization for these services, so we don't really have to worry about medical necessity because we've essentially already got it screened. But it's not correct. Managed care companies can go back, retrospectively and look at stuff, and they do that on a regular basis, and that's the auditing process. So really make sure you have a clinical expert to look at charts and map what they see in the chart to the medical necessity requirements of that payer is enormously important. I've seen, agencies or entities around the country where it looks like they have many more patients than they really have because they're not carefully looking at the medical necessity criteria. And what we're really doing is pushing patients into much higher levels of care where there's greater margin, and then they essentially want to get out before there's the audit. Move forward. Just kind of build off of that. You want to look at, you have people that are looking at charts. You want to look at why people are actually admitted. And if they actually have kind of a clinical opportunity to get better and improve, the red flags you always want to look at is what we call maintenance level care, where patients come in, but there's largely no expectation for improvement. They've done this multiple times before. And when you're looking at facilities for purchase, you want to look at not just levels of care, but you want to look at duplicated patients that are being admitted into the facility. So just look at volume of service. One patient could be admitted 10 times with multiple services. Likely that's a medical necessity issue. So you want to look at unduplicated patients in addition to volume of services. Other things you want to look at include things like agents that require attendance at multiple different counseling sessions because they ascribe it particular clinical model. From a necessity perspective, services have to be individualized to the patient. You can't just simply say one patient goes to everything. A key area is signatures in relation to medical necessity. There's certain states that require a physician's signature on treatment plans. Otherwise, doses are recoupable. It's not common that an agency will make a mistake or not understand what that means, and they will have an advanced practice nurse sign because he or he can prescribe, but it has to be a physician. So looking at those rules is really important. Looking to see if the agency has a compliance team that oversees medical necessity is important. And looking at if they've got a continuum of services, how they figure out who moves from one service to another is really important. In behavioral health, it could just be, kind of a line clinician making that decision. And if it's the case, they likely have kind of relationships and friendships with other people in the facility and really not kind of a gatekeeper for that service delivery piece. And then finally, looking at the issue of noncompliance. Running like an IOP or a PHP, but running very high kind of no-show rates for their patients, which then draws the issue of medical necessity in question and who's actually there. Moving on. When you think of medical necessity, the core of medical necessity is documentation. And documentation is really the gold standard in substance abuse or behavioral health as a whole in terms of what providers are actually doing. And I can tell you that if you ultimately want to look at quality, open medical record, because largely in this field, people document literally what they did. It will give you a very good indication as to the quality. And one of the things that we typically look at is what we call the golden thread. Open up the chart, look at the assessment of the patient, look at formulation, which kind of synthesizes the information. There should be a level of care determination, a term plan, and then progress notes, and it kind of keeps going round and round. And so the facilities with a better quality of care, the better compliance, much better kind of golden threads than the agencies that do not. And when you start picking up documents, compliance perspective, there's the idea that every document should be able to stand on its own. And in agencies that are weaker, documents never stand on their own, and you need staff to essentially describe what it is they meant in the documentation. It's always a red flag for a problem. Moving forward.
And this is Kevin Malone. I wanted to also jump in on that last slide and sort of highlight, that there's, similarly with what I was raising before, there's also a lot of innovation happening right now with regards to documentation options. We'll streamline this and make it even easier for provider platforms. Obviously, historically, especially Part 2 providers have really struggled to find compliant EMR options that will allow for sort of the streamlined process for, collecting the golden thread and maintaining it in a sort of easily usable manner. I'm sure many folks in the field know like a preponderance of pen and paper and written notes in medical records in the addiction treatment community is certainly higher than in many other fields. But there's been, a lot of work in this area recently, and some of the products like the ASAM's Continuum product that sort of really operationalizes all of their assessment and patient placement protocols into a variety of EMRs with a growing adoption rate. Those sorts of things really separate a provider from the pack, and being able to have really robust assessments that automatically lead into treatment plans and progress notes, and really support your medical necessity determinations, and sort of being like forward thinking about the way you acquire EMRs and utilize some of these assessment tools that are on the market will make a big difference around having this documentation in place.
Thanks. Just briefly, around the documentation piece, I laid out just some of the key pieces you want to make sure is in every progress note. With being said, one of the other things you always want to look at in documentation is that there is active patient or client participation. That is usually evidenced by a signature on a treatment plan. With that, you want to make sure progress notes have pieces like date, length of session, location. From a quality perspective, you want to make sure there's a description of the clinical intervention that was provided, individual present, type of service, and kind of key areas that need follow-up post-session. Length of stay. So this is area number 5, and you want to know the length of stay for each patient in each level of care. And you want to understand really, are the levels of care being authentically provided? Meaning that you take a residential and you assume maybe a patient stays for a month or 6 weeks or 2 months, and then end up in a partial program, but the average length of stay in that program is 3 or 4 days, and you don't see much utilization in the other levels of care. It draws into question if there's a true authentic continuum, or if what's really happening is patients are being seen in higher levels of care. Actually, the entity knows that they'll likely relapse, and then they push back to the higher level of care. So you want some to really look at the different levels of care, what the readmission rates are, and you want to understand from a substance use perspective, if a patient relapses, how do they determine what level of care a patient actually goes back to? Because someone relapses doesn't mean automatically they go back to the highest level of care. So that's a key piece, and it obviously becomes a huge kind of revenue driver at the end of the day. Moving on. Staffing. You make sure when you look at any program that they have the correct staffing from regulatory perspectives and safety perspectives. Back to the issue of certificate of need and licenses. So if you're purchasing a substance use facility, it's really possible that many of the staff will have substance use credentials. Typically, however, are not allowed to see patients who have primary mental health problems. However, you're probably looking at half to 2/3 of all patients coming into a facility having mental health problem. And the complexity there is that if a patient they're seeing has a greater kind of need for mental health services and substance use services, from a clinical perspective, if you only have a substance abuse license and you have staff that only have substance use credentials, they're not allowed to see that patient. So understanding the license and how it relates to the staffing is really important. And then the third piece would be if you were considering add-ons to what it is you purchased, you understand who staff are that you need to actually provide that service, because it's uncommon that licensed clinical professionals are typically more expensive than substance use professionals. And so there's some major areas to look at in relation to staffing. 2 quick areas. One is relation to medical director. A lot of these just use a figurehead medical director, meaning she or he isn't there. That's a problem. They need to be there, and staff need to know who they are. And then you look at your clinical infrastructure. Who's your clinical director? Do you have a clinical kind of chief operating officer, and how that clinical infrastructure drives what goes on? Next slide. And contracting, billing, collections. Look at your in-network and out-of-network ratios. We can talk more about that later. Make sure co-payments are collected. Some of the stuff that people are looking at tend to be kind of mom-and-pop shops. Making that co-payments and deductibles are actually kind of observed is really important. Look at rates and look at the last time they were negotiated. In summary, on the next slide. Number 1, a clinical expert who's licensed, knows what they're actually looking at. You want that person to understand the quality of services being provided and whether they meet best practice standards. The regulatory requirements, facilities meet them, and if there's the opportunity for add-ons. You understand the facility safety standards, and if there's a history of critical incidents. You understand medical necessity, and if it's consistent with history and payer standards. Similarly, with billing and coding, and if it's done correctly. And then similarly, understand the staffing, and if it meets regulatory and payer requirements. Thanks so much for your time. Move on.
Okay, we're going over to Paul.
Thanks, Gary. My role today is to cover principally two areas. One, core housekeeping issues that will allow you, and my remarks are primarily addressed to potential sellers, those looking for partners or investors, to avoid surprises and to give you a head start on a process that can be overwhelming if you aren't prepared for it. I want to speak for a second about pick the right partner, because frankly nothing is more important in this transactional perspective than picking the right partner. That means someone who is a cultural fit with you, someone who can help you achieve your business goals, and finally somebody you can work with. And I'm suggesting, or will suggest to you, that being able to work with one, a great way to determine whether that's possible is working through the indemnification provisions of the agreement in advance. I'll hit that starting on slide 28. Certainly a lot of things that can be done to prepare. Writing just a couple. Do you have conflicts of interest? Meaning, is your organization currently involved in transactions that favor an officer, someone on the board, or an employee? If so, ask yourself whether those relationships are critical, and if they are critical, think through them and be prepared to explain to your potential partner, why they're so important. A second tip I'd give you is get your hands on a due diligence list that you should expect to receive once your process starts, and look at the items that you will be asked to provide. I think that's a very practical and real-world way to get prepared for a transaction and for the information needs that are generated through the course of the transaction. And again, the goal is to avoid surprises. So my advice is to not only collect the information on the list, but review it and make sure you understand it, and make sure that you can address any areas that might cause you any discomfort as you go through the transaction. Then speaking to slide 29, and as Scott frankly is described in great detail, compliance is the thing that very often trips up sellers in these situations. Surprises can be found if programs are not run effectively and frankly correctly. And that can be hard to do if you're a smaller organization, a startup organization. But here is to think about these issues in advance, be thoughtful about compliance and compliance programs, and do your best to be compliant so that you can demonstrate that to your potential partner, who will, on my experience, be very interested in this area. And while they don't or won't expect a full-blown compliance program, they will at least expect that some thought has been given to this, that the outline of a program exists, and that your intentions are proper. Excuse me. Then going on to slide 30, one other, as Scott again said, area of value destruction relating to compliance is billing and coding issues and errors. And once again, I urge you to try to spot those in advance if that's possible. Then on 31, insecurity, of course, is an issue for every organization in today's world. Please recognize, however, as I know you do, that the population being treated in these or with these organizations is an incredibly unique population, and one to which unique obligations and important obligations are owed. Kevin, I think you wanted to hit have a career, yes, especially on Part 2 protections. Yep.
I thank you very much. I think to build on our previous two discussions here about some of the unique issues and where there's some really ongoing movement now is around Part 2. Providers have dealt with a lot of uncertainty about enforcement, about guidance out of SAMHSA for a long time, and there's been a flurry of regulatory and sub-regulatory activity that's ongoing right now that really is a challenge that providers need to be on top of as they go into any potential acquisition to really both demonstrate their value to potential other partners. I think being able to have the can set forms in place that comply with the most recent version of the Part 2 regulations that allow for participation in integrated networks in an effective way is not an easy task. And I think it takes some real planning on the part of leadership and compliance officers to make sure that those forms are collected and filled out effectively during the intake process, and that they're drafted very carefully in partnership with other organizations that need access to that information in order to operate in a clinically integrated manner. But in addition, it's a moving target, and I think there's been some legislation moving right now in Congress to significantly reform Part 2's obligations, and so it's an area that will potentially change really soon, and it's definitely something to keep on top of as you are moving forward with any potential partnerships.
Thank you. So if you have moved into substance abuse, behavioral care, psychiatric care from another area of the healthcare system generally, don't assume you know the rules. The rules here are, as we're very different, and certainly worth the attention. On the next slide, quality of earnings, of course, we're talking here about a transaction involving the future of the business, so the quality of earnings will be important. I think someone has already mentioned the fact that businesses often are run on a cash basis and will transition to the accrual basis during the course of diligence. Kevin, I think you also had a point here that you wanted to make.
Yeah, I think, sort of zooming back out across all of the discussions that we've been talking about, I think that, right now, especially as the Mental Health Parity and Addiction Equity Act gets enforced more through state Medicaid programs and in the commercial market, and there's a growing effort through ASAM and state regulatory agencies to push for greater regulation of quality in addiction treatment. At the same time that there's a lot more enforcement around some of the fraud and abuse problems in the addiction treatment community. There's really a lot of opportunity right now for really high quality providers to improve their pay relationships, and get more involved and provide a greater scope of services, as we've discussed. And I think the strong and weak providers will really be identified in the quality and integrity of those the sort of network provider agreements. And I think it's definitely something to be working on actively right now, because it's a great opportunity right now for high quality providers to play a really important role for a lot of the payers out there in both the commercial and public markets. So I just want to emphasize how great of an opportunity, but also challenge it is, that if you're not demonstrating that through the quality of your earnings and all the things that we've discussed, it's really going to have a big impact on the valuation that you can obtain.
No question. So moving to the next slide. Picking the right partner. So shifting away from things you can do to prepare to engaging in the possible transaction. Picking the right partner and the importance of doing so, frankly, cannot be overstated. The current market allows organizations looking for partners to act carefully and to take their time. As Erik said, it's not a fire sale right now. And take advantage, if you're interested in a transaction at this point, take advantage of the market and pick the right person or entity to work with. And culture is cool. Do they share your mission and goals? Do you agree on what the future of your organization looks like? If you don't, then life may be too short to go with that particular partner. There may be someone else out there that's a better fit. I would encourage you to look for them. One way, flipping in the next slide, to get a check on whether or not you're dealing with the right person is to start talking early in the process about how post-closing liabilities that arise or that are identified post-closing, how those will be treated. Will those be dealt with by the post-closing organization, the system that you've formed, or will your partner expect for you to pay for them? There's no right or wrong answer here, but understanding where those liabilities will fall back to you or forward to the organization is something that's critical in order to make sure that you get the benefit of your bargain and that you understand, frankly, what you're going to end up with at the end of the day. Now, subject to the caveat here that in larger transactions with financial sponsors, representation warranty insurance may provide an answer and step in to fill the financial gap created by liabilities that arise after the transaction. The terms of the contract that you enter into and the indemnification provisions of that contract, as discussed on the next slide, will determine more than the structure of the transaction where those liabilities fall. And when you're talking about indemnification, again, hopefully early in the process, what length of time will you, the seller, be responsible for pre-closing liabilities? Is there going to be a cap on your liability? Will your partner or buyer expect you to escrow a large portion of the funds to be paid at closing? These are questions that you should ask. Again, asking these questions early will allow you to determine whether or not you can work with your partner, your goals are aligned, and whether your understanding of the future is the same. And again, most importantly, and on my happiest note of the day, this is all about making sure that you get to keep what you bargained for. And with that said, Gary, I'll turn back to you for questions.
Right. The opportunity to ask questions on the chat box. So please go ahead. We do have some questions here. What are the questions? Medical director agreements and what potential exposures there are there. And I can address that. With those head on. And there's really two main issues with medical director agreements. Number one, I believe, like Scott indicated, they have to actually be doing what they're supposed to be doing and overseeing the clinical care, the clinical policies and procedures, the clinical policies and procedures periodically to see if they need to be updated, and just overseeing the care and any incidents and things like that happen. And the key there is to make sure they're doing it and make sure they're documenting it. Documentation, I can't stress enough. The other potential exposure area in medical director arrangements is are you the medical director who's a major referral source? So who maybe has, whether it's a primary care doctor or mental health, in the mental health field, like psychiatry, or if they're making referrals to your organization, that what you're paying them is fair market value, bona fide services. So it goes back not only the documentation of doing, but also how much are you paying them, making sure that's fair market value. The question here.
And Gary, if I could just jump in on that. Jump on the medical thing for 1 second.
One way or another. I guess the issue is that a client that the buyers are looking out for. Scott, or anyone else have an answer to that? Anyone? So the question was about high turnover rate, and I guess input from many of the panelists, my answer is that if you're turning patients and discharging them, their treatment is over, and they're appropriate for a discharge, that would be a concern, that there's a bringing new patients and get reimbursement and underserving, undertreating patients. So that could be a problem, but on the other spectrum, treating patients longer than you do residential facilities.
Gary, can you hear me?
So I think appropriate care and appropriate discharge is important to look at. And I just want to highlight, slide 29, even agencies and organizations in the substance of this space really need to be looking at business checklists and also all the components of what that's about regarding clinical compliance and because a potential buyer or investor going to look very deep at what you're doing and making sure that you're providing the right and right level of clinical care, and also that you're acting in a compliant way.
Hey, can I say a word?
I think our time is up. I don't
Gary,
see any other questions. So I just want to thank the panelists for joining this webinar and giving us their insight. I just want everyone to know that there will be another webinar focused on autism providers, in the next 2 weeks, and we hope you'll all join that as well. Thank you much, everyone.
There we go. I think Scott wanted to jump in with a comment. Scott, go ahead.
Oh, I was just going to follow up on the medical director piece and also on the staff turnover piece. So on the medical director side, one of the best strategies to really know if the medical director is authentic in there is to talk to the staff and ask the staff what the role is of the medical director, how often they're there, what the relationship is like with that person. So making sure you have someone to go on site and into the staff and spend time with them is really important. The other I just wanted to comment on was the turnover piece, and there's two pieces to the turnover. One is rapid patient turnover, which likely or oftentimes speaks to show of quality of care. You can also, however, in the area of substance abuse, have rapid staff turnover. And understanding what accounts for that staff turnover is really important. And looking at, for agencies that end up with higher staff turnover, usually they end up with problems in relation to staffing ratios. You want to look at, agencies with higher turnover, how they credential the staff that come in through the door, do background checks, who are the people actually providing service, because the turnover rate of the staff, ultimately the less people that are actually, in the area to provide services. And so the quality of the person can decrease. So really making sure you interview staff, understand them, understand their credentialing process, all really important to both of those areas. Thanks.
Thanks for adding that. So with that, I want to thank everyone for joining us. This does conclude today's webinar. In approximately 2 to 3 business days following the webinar, Epstein Becker Green will communicate the availability of the webinar recording and access to the PowerPoint materials. Thank you much.